Hi guys, welcome back to ECG Insights. Today we're going to be answering the question, what exactly is normal sinus rhythm? And we'll be identifying 10 things you must look for before calling an ECG normal. So let's begin. So this is the ECG we'll be using as an example as we go through the 10 points. So the first thing we're going to be looking for is that the rhythm is regular. This means that there should be equal spacing between each QRS complex. Now, if the spacing between each QRS complex is not equal, then the rhythm is irregular. And irregular rhythms can either be regularly irregular, so there's some sort of repeating pattern between the QRS complexes, or they can be irregularly irregular, where there's no repeating pattern between the QRS complexes. So on this ECG, we can see that the QRS complexes are evenly spaced, so this is a regular rhythm. Now, common reasons why a rhythm might be irregular include sinus arrhythmia, atrial fibrillation, premature ventricular contractions and premature atrial contractions, and second or third degree heart block. So we'll now look at a few examples of irregular rhythms. So here's an example of atrial fibrillation. So this rhythm is irregularly irregular, as there's no repeating pattern to the QRS complexes. This is an example of second degree heart block, and again, this rhythm is irregularly irregular. This is a premature ventricular contraction, so this is a beat originating from within the ventricles, which is causing an irregular rhythm. And this is an example of a premature atrial contraction, so this is a beat originating from within the atrium. So the first thing we're looking for on an ECG is that the rhythm is regular. So we'll now move on to the next point. Next, we're going to make sure that the heart rate is between 60 and 100 beats per minute. Anything less than 60 beats per minute is bradycardia. Now this may be normal for the patient, for example athletes with high vagal tone, but this can also be a side effect of medications such as beta blockers and calcium channel blockers. It can be a sign of conduction disease such as second or third degree heart block or SA node dysfunction. And you can also see bradycardia in patients with hypothyroidism, hypothermia, and electrolyte disturbances such as severe hyperkalemia. Now, anything over 100 is tachycardia. Now, this can be a normal physiological response to things like pain, anxiety, and exertion or exercise. However, it can also be a sign of an acute illness or injury, such as an infection or blood loss. It can also be caused by certain prescription medications and also illicit drugs, such as cocaine and amphetamines. Now, tachycardia can also be caused by arrhythmias such as supraventricular tachycardia, so SVT, or ventricular tachycardia, so VT. Now on this example ECG, we can see that there are about 3.8 large boxes between each QRS, and 300 divided by 3.8 is going to give us a heart rate of about 80 beats per minute. Now if you're not sure how I worked out the heart rate from this ECG, I've got a short video on calculating heart rates based on ECGs that I'd recommend you watch. So we'll now look at a few examples. So here's an example of bradycardia in a patient with second degree heart block. This is an example of sinus tachycardia in a patient with an infection. And this is an example of fast atrial fibrillation in a patient who is experiencing palpitations. So that's the second point. We're looking for a heart rate that's between 60 and 100 beats per minute. So we'll now move on to the third point. So point number 3, we're going to look to make sure that there is a P wave for every QRS complex and a QRS complex for every P wave, that the PR interval is between 120 and 200 milliseconds, and that the PR interval is constant. So if the PR interval is short to begin with, which is less than 120 milliseconds, we'd be thinking about pre-excitation syndromes such as WPW or LGL, or maybe a junctional rhythm, so that's a rhythm that's originating from within the AV node. You'll also see short PR intervals in pediatric patients, so especially with a patient that's under 2 or 3 years of age, but that is normal for this age group. Now, if the PR interval is longer than 200 milliseconds, so that's a long PR interval, this is first degree heart block, and this just means that the electrical signals are taking longer to get through the AV node than they normally would. And if there are P waves which are not followed by a QRS complex, this might suggest a second or third degree heart block. And if there are QRS complexes without a preceding P wave, this would suggest something like a premature ventricular contraction. So on this example ECG, we can see that there's a P wave followed by a QRS complex, and each QRS complex has a P wave just before it. So there's a 1-to-1 ratio of P wave to QRS. And we can also see that the PR interval is less than 200 milliseconds or 5 small boxes, but it's also more than 3 small boxes. So this is normal. We'll now look at a few examples. So this is an example of a patient with first degree heart block where the PR interval was more than 200 milliseconds. So that's point number 3. We'll now move on to the fourth point. So the fourth thing that we're going to be looking for is that the P waves should be upright in all leads except V1 and AVR, and they should have a normal morphology. So the reason that P waves are negative in AVR and either negative or biphasic in V1 is due to the location of those leads relative to the path of depolarization across the atrium. So here's an image of the heart. Now this arrow shows the general direction of depolarization across the atrium. Now here's lead AVR, and we can see that the atrial depolarization is moving away from this lead, and that's why the P wave is negative in AVR. Now V1 sits about here, just on top of the atrium, so the electrical signals from the SA node are initially moving towards V1, they're then going to pass V1 and start moving away from V1. And this is why we often see a biphasic P wave in lead V1. Depending on the exact position of V1, exactly where you place it, sometimes you'll get a negative P wave in V1, but generally the P wave should not be positive. Now, if you're seeing P waves that are negative in other leads, this might suggest premature atrial contractions or junctional beats. Now, the other thing we need to look for are what are called bifid P waves. So that's a P wave with 2 separate peaks, and this can suggest left atrial enlargement. Alternatively, the P wave might be peaked, which is just very pointy, and this can suggest right atrial enlargement, and it's something you'll often see in patients with pulmonary disease like COPD. So in this ECG example, we can see that the P waves are upright in all leads except AVR and V1, and none of the P waves appear to be either bifid or peaked. Now here are a few examples. So here's an example of a peaked P wave in a patient with COPD, which has caused structural changes to the right side of the patient's heart. And these are 2 examples of bifid P waves in a patient with aortic stenosis and left atrial enlargement. So that's the fourth point we're looking for. We'll now move on to point number 5. So point number 5, we're going to check that the QRS axis is normal. So that's anything between negative 30 degrees and positive 90 degrees. So here's a diagram of the cardiac axis as a reference. So first, left axis deviation, which is an axis between negative 30 degrees and negative 90 degrees, can be caused by things such as left ventricular hypertrophy, left bundle branch block, inferior MIs, and left anterior fascicular block or right ventricular pacing. So that's when the patient has a pacemaker in the right side of their heart. Right axis deviation, so that's a QRS axis between 90 and 180 degrees, can be caused by things such as right ventricular hypertrophy and right ventricular strain, or left posterior fascicular block. Now occasionally the patient will have what's called extreme axis deviation, which is an axis between negative 90 degrees and 180 degrees, and this can be caused by ventricular rhythms, so that could be VT or PVCs. It can also be caused by severe hyperkalemia and severe right ventricular hypertrophy. Now on this example ECG, we can see that lead 1 is positive and AVF is positive. So this patient has a normal axis. Now here are a few examples. So this is an example of a left axis deviation in a patient with left bundle branch block. We can tell this is LAD due to the positive lead 1 and the negative AVF and negative lead 2. Here's an example of a patient with right axis deviation. So we can tell it's RAD due to the negative lead 1 and the positive AVF. So that summarizes axis. That's point number 5 that we're looking for. So we're looking for the patient to have a normal axis. So that's anything between negative 30 degrees and positive 90 degrees. So we'll now move on to point number 6. So the next thing we're looking for is for the QRS width to be less than 120 milliseconds or 3 small boxes. Now anything more than this is a wide QRS complex. And a wide QRS complex is typically caused by abnormal or slow pathway of conduction through the ventricles. So causes include left and right bundle branch block, ventricular rhythms, hyperkalemia, and sodium channel blockers such as tricyclic antidepressant toxicity and hypothermia. Now in this example ECG, we can see that the QRS is narrow, so it's less than 3 small boxes. So this is a narrow QRS complex, which is normal. We'll now look at a few examples. So here's an example of some ventricular beats in a patient with complete heart block. And here's an example of a patient with right bundle branch block with wide complex QRS as well. So that's point 6 we're looking for. We're looking for a narrow complex QRS, which is anything less than 120 milliseconds or 3 small boxes. So we'll now move on to the 7th point. So the next thing we're going to look for is to make sure that there are no pathological Q waves. And a pathological Q wave is a Q wave which is suggestive of disease or injury to the heart. Now, small Q waves are normal in most leads except V1 to V3. A Q wave is going to be pathological if it's greater than 40 milliseconds wide, so 1 small box, greater than 2 millimeters deep, or if its depth is more than 25% of the QRS amplitude, or if it appears in leads V1 to V3. Now, typical causes of pathological Q waves include MIs, which are either old or new, cardiomyopathies, and you'll often see them in lead placement errors. So in this example ECG, we can see that there are no Q waves in any of the leads, which is normal. So quite frequently ECGs just won't have Q waves in any leads. So we'll now look at a few examples. So here's an example of some normal small Q waves in a healthy ECG. We can see that they're narrow and they're small in amplitude. So they're less than 40 milliseconds wide and they're less than 2 millimeters deep. And they're not appearing in leads V1 to V3. Here are some very large, deep, and they're quite wide Q waves in a patient that's having an anterior MI, and these Q waves are clearly pathological. So that's point number 7 that we're looking for to make sure there are no pathological or abnormal Q waves. We'll now move on to point number 8. So the next thing we're going to be looking for is to make sure that the R waves grow from at least V1 to V4. It's also sometimes defined as an R wave that's greater than 3 millimeters in V3. Now, if this is not the case, then this is called poor R wave progression. So this has several different causes, including MIs, either old or new, left ventricular hypertrophy, and right ventricular hypertrophy, including cardiomyopathies. It can also be caused by lead placement error, and it can sometimes be a normal variant in a patient's ECG, so it's not a sign of anything sinister. Now on this example ECG, we can see that the R waves grow from V1 to V4, and the R waves in V3 look like they're about 3 millimeters. So we can say that this ECG has normal R wave progression. So we'll now look at an example. So this is an example of a patient with poor R-wave progression due to an old anterior MI. And if you remember the ECG from the previous slide, so slide number 7, when we were looking at Q waves, patients, if they lose their R-wave progression, they'll also then develop Q waves in an acute MI. You can see that this patient, they've lost their R-wave progression and now they have wide Q waves as well. So often the presence of pathological Q waves and poor R-wave progression in the anterior leads will go hand in hand. So that's point number 8. We're looking for normal R-wave progression. We'll now move on to point number 9. Right, we're now going to make sure that the ST segment is isoelectric in all leads except V1 and V2. And this is because it's normal for patients to have a small amount of elevation in their anterior leads. Now, there are lots of different things that can cause either elevation or depression of the ST segment, and you really need to look at the rest of the ECG and the patient's presentation as a whole to determine what might be causing it. But some common causes include acute coronary syndromes, pericarditis, early repolarization and left bundle branch block, left ventricular hypertrophy, including a strain pattern with the LVH, right ventricular pacing, electrolyte disturbances, and certain medications such as digoxin. Now, on this example ECG, we can see that there doesn't appear to be a significant amount of elevation or depression in any leads. So we'll now look at a few examples. So this is an example of early repolarization in a 35-year-old male, and this was the patient's baseline ECG, showing this anterior elevation. This ECG is showing a patient with left bundle branch block, again with anterior elevation, which is normal in LBBB. This ECG is showing a patient who's on digoxin, which is a cardiac medication, and it characteristically creates this downsloping ST segment depression in many of the leads. And this ECG is of a patient who's having an anterior lateral MI. We can see elevation in leads V1, V2, V3, AVL, and maybe lead 1 as well, although the tracing is not very good there. And then we can see the reciprocal depression in the inferior leads. So leads 2, 3, and AVF have ST segment depression, which is reciprocal to the elevation. So that's point number 9. We're looking to make sure that the ST segment is isoelectric in all leads except V1 and V2, and maybe V3. We'll now move on to the 10th and final point. Right, so the final thing we're going to look at are the T waves and the QTC interval. Now, the T waves should be upright in all leads except AVR and V1, where they may be negative or inverted. However, isolated T wave inversion in lead 3 is a normal variant in some patients. Now, common abnormalities we need to look for when thinking about the T waves include T wave inversion in any other leads, or especially if the T wave inversion is new for that patient. We also want to be looking for hyperacute T waves, so that's a T wave which is tall and wide. We want to be looking for peaked T waves and biphasic T waves. And thinking about the QTC, so that's the corrected QT interval, it's considered long if it's over 440 milliseconds in men or 460 in women, although these numbers do change slightly depending on what source you use. However, anything over 500 milliseconds is considered high risk for developing arrhythmias such as torsades, which is a type of polymorphic VT. So we'll now look at a few examples. So this is an example of a patient who has acute biphasic T waves in his anterior leads, and this was a patient who was having quite a severe hypertensive crisis. And this is an example of a patient who's having an MI and he's got hyperacute T waves. So the thing to note with the hyperacute T waves is that the QRS complex just before the T wave will easily fit inside that T wave, and that's a bit of a giveaway. If you can fit the QRS complex inside the T wave, then there's a good chance it's hyperacute. So that was the 10th point we're looking for. We want to look at the T waves and we want to look at the QTC interval. So we'll now move on to summarize those 10 points. Right, so we've now gone over the 10 points and we'll summarize them very briefly here. So you can call an ECG normal if the rhythm is regular, the rate is between 60 and 100 beats per minute, the P waves are upright in all leads except V1 and AVR, and they have a normal morphology. There's a P wave for every QRS, and there's a QRS for every P wave, and the PR interval is between 120 and 200 milliseconds, and that PR interval is constant. The QRS axis should be between negative 30 degrees and positive 90 degrees. The QRS width should be less than 120 milliseconds, or 3 small boxes. There should be no pathological Q waves. So remember, that's a Q wave that's deep or wide relative to the QRS complex, but small Q waves are normal. There should be normal R wave progression. The ST segment should be isoelectric in all leads except leads V1 to V3. And the T waves should be positive in all leads except V1 and AVR, and there should be a normal QTC. So that summarizes the 10 points you should look for before calling an ECG normal. I hope you enjoyed this video. I hope you found it useful. If you did, subscribe to keep the page going, and I hope to see you again next time. So bye for now.